Here, let me set this up for you. So we have the afferent arteriole. I'd like for you to begin up there. Afferent arteriole. How did you give rise to this? It was a renal artery, and it came in, and what did it do? Interlobar. What was next? Interlobular. What's the name? Well, you have your arcuate, and then you have your interlobular. What was another name for that? Cortical radiate. Then you have the afferent arteriole, and here we are. I want you to come towards the glomerulus. You're going to form a tuft of capillaries. I've mentioned that before. The afferent arteriole is coming in, and you see all the structures there? That's a lot of structures. Let me set each one up. What's inside my afferent arteriole? I'm sorry, what? I didn't hear you. One more time. Good. Plasma. Excellent. So you have plasma coming through there. Good. Can you hear me? Loud and clear. Afferent arteriole. Plasma. Filtering through. Tell me about hydrostatic pressure from physio. Increased. It ensures filtration, right? Ensures filtration. Through what? Through the endothelial cells, across the basement membrane, into where? Into the Bowman space. Okay, so now, tell me about these cells that we see in green. They're called juxta-glomerular cells. What are they responsible for? They're responsible for measuring the pressure within the afferent arteriole, aren't they? So, let's say that you have decreased perfusion to the kidney. How did that occur? You tell me what the diagnosis is. An older patient, male, approximately 52 years of age. Blood pressure, 160/90. 3 different times on 3 different clinical visits. So far, diagnosis, hypertension. We're not done. Now, you go ahead and check the kidney, you auscultate the renal area, and you hear noise, bruit. Hear renal bruit. Give me diagnosis. What's causing the hypertension? What's causing the bruit? A 52-year-old male, the bruit is caused by atherosclerosis. Where? Renal artery. Good. What caused the 160/90? Secondary hypertension. Why? This will explain everything. The renal artery has been cut off. Take a look at the previous slide if you need to, so that you see the positioning of the afferent versus renal artery. Right? Now, you have decreased perfusion through the afferent. This is not good. You have decreased perfusion. That kidney must maintain GFR at all times. Tell me what the juxtaglomerular cells are going to release here due to renal artery stenosis, secondary to atherosclerosis. Renin. Good. What's the name of that receptor that those JG cells have? JG, juxtaglomerular. Beta 1. What are they going to release? Renin. Good. Continue the story. Renin. Angiotensin 2, aldosterone. What's my blood pressure in my 52-year-old male? 160/90. Was this primary or secondary hypertension? Secondary hypertension, huh? Secondary hypertension. You got this? You better. You have no choice. You have to know this. Next. What's on the other side? Well, the afferent arteriole with the JG cells are going to communicate with a distal tubule. What's in there? What's in the distal tubule? You wish it was me being flushed down the toilet. It's not. It's urine. That's urine in the distal tubule. You see it? Okay, good. So that's urine in the distal tubule. And what's sensing the urine? It's not the juxtaglomerular cells. It's the macula densa. Are we clear? So in physio, you did a little bit of a reflex between the macula densa and the juxtaglomerular cells. Yeah, you did. And that was called the tubuloglomerular feedback. We'll get to it in due time. Not yet. And the macula densa is sensing what? The sodium and chloride within the urine. Are you putting all this together? I hope so. I just gave you one example. Now, as we progress through here in this lecture series, we're going to go ahead and talk about the efferent arteriole in great detail. We'll talk about the afferent arteriole in great detail. We'll bring all these structures together, and we're going to put in more and more and more pathologies. It'll be fun. Trust me. All we're doing is laying down foundation. Are you having a good time? Smile for me. Okay, so let's take a look at this interesting graph. Quickly, it's called autoregulation. Okay? Autoregulation. Let me set this up for you. On the x-axis, perfusion, in other words, blood pressure. And on your y-axis is your tissue flow. Okay? Now, tell me about autoregulation that you learned of. How important is that for our body? Really important. What do you mean? Autoregulation in the brain? What does that do? It ensures that the brain receives enough oxygen at almost all times. All right? So as soon as you have any hypoxia, What is that? What are the cerebral blood vessels doing? Vasodilation, right? What did I just say? As soon as the patient has hypoxia for 5 minutes, your neurons are going to die. You can't do that. So as soon as the body senses and the central chemoreceptors senses the carbon dioxide, then what do the cerebral blood vessels do? Autoregulation, vasodilate. What about the skeletal blood vessels when there's hypoxia? Vasodilate, right? And what about the kidney? This is all part of autoregulation. Very important in all the major organs, brain especially. But you also have it taking place in the kidney as well. And that's what this entire graph is about. This green line that you're seeing, you see where it says the Y curve? Take a look at Y curve. Take a second here. Okay. Y represents perfect autoregulation. How do you know? I want you to take a look at that line between point A and point B. Take a look at the line between point A and point B. Is there any fluctuation there? Perfectly horizontal. That means that, tell me about the y-axis. What does that represent? Flow. So the flow, did it change at all from A to B? No, it didn't. Point Y stayed the same. How is that possible? So what did change between A to B from the green line, or in general? It's the pressure. So go down to the x-axis. A represents a perfusion pressure of 40. B represents a perfusion pressure of 140. Wow, that's a difference of 100 millimeters mercury. And you're telling me, Dr. Roger, that between A to B, that there's no pressure, no change in flow? That's exactly what I'm telling you. How did that occur? Auto-regulation. So what does that mean to you? There was no communication with the brain. There was a reflex in which it was able to handle the pressure at the level of the kidney just like that, like a reflex. So now, this is autoregulation. You pay attention. As the pressure starts dropping from 90, point C is normal. Point C, as in Charlie, is 90. Let's call that normal. As your pressure starts dropping all the way down to 40, what do you expect your blood vessels to do so that you maintain proper flow? A represents vasodilation, part of autoregulation, so that the flow doesn't diminish. The pressure starts decreasing, but autoregulation causes vasodilation. That's point A. Whereas if you have point B, then what does that mean to you? Your pressure is increased. Autoregulation tells your blood vessels to do what? Vasoconstrict. We have B. We pretty much identified the perfect autoregulation points on this line for horizontal. That is as far as I'm going to go with you on this. I need you to at least understand autoregulation and its specifics. At any point in time, any one of your license exam could ask you about curve X, in which there's absolutely no autoregulation, and that dashed line represents mild autoregulation. I'll go as far as that. But your focus right now in pathology is going to be between A and B, that green line exhibiting perfect autoregulation. Let's move on.